Okay. Good morning, everybody. My name's Rachael Morton, and I'm the President of the Health Services Research Association of Australia and New Zealand. And on behalf of the Organising Committee, Laura Wilkinson-Myers, Megan Campbell, Catherine Harding, Vanessa Selak, Tilly Payne and Sarah Green, it's my great pleasure to welcome you to the Health Services Research Association's end-of-year event, Health Services Researchers Partners for COVID-19 Response and Recovery. Before we get underway, I'd like to acknowledge the traditional owners of Australia. For me, this is the Gadigal people of the Eora Nation, and we pay our respects to elders past, present and emerging. I'd also like to say kia ora koutou, a warm welcome to our attendees from New Zealand. I would also like to acknowledge the tangata whenua and mana whenua of the lands where you meet to join us today. We have a very exciting program, and just to run through how this will work, we have a keynote speaker, and then the program is split into 3 sessions. The first being telehealth and primary care, the second being discrete choice and preference studies, and the third being models of care and genomics. So the way this will work is that each of the speakers selected from abstracts will have 7 minutes to present and 3 minutes for questions. Please type your questions into the Q&A button, which you can find at the bottom of your Zoom screen. And these questions will then be asked by the chairperson for that session. We'll have 2 short breaks, one at 11:10 and the other at 12 o'clock. That's Australian Eastern Standard Time. And then we'll have the HSRAANZ awards, which will be at 1:20. At 1 o'clock, at the end of the sessions, we'll have a 20-minute facilitated discussion to talk about any of the other topics that have emerged from the day. And a reminder that the HSRAANZ AGM is scheduled for 2 p.m. Tilly Payne is our timekeeper. She's going to be providing an audio cue for all speakers when they have 1 minute left to present, and then 1 or 2 minutes left for questions. Tilly, can you just take yourself off mute and let everybody know what sound you're going to make? Okay, terrific, thank you. And just to let you know that this event will be recorded. I'd now like to introduce our invited speaker, who is a Professor of Health Services Research and Director of the Australian Health Services Research Institute at the University of Wollongong. Her extensive body of research, particularly in aged care, has led to a redesign of the Australian National Aged Care Classification and funding models. To talk to us today on a very important topic, aged care homes, the weakest COVID-19 link, please welcome Professor Kathy Eagar.
Thank you very much, and I will try and share my screen. Thank you very much, and I would like to join with you in acknowledging the traditional owners of the land. I will move through, and I'd like to start with this, which is a high-level analysis, I think, of how any system works. And I think if you're an early career researcher, this is probably something that's sort of worth having a look at, of how do things actually work. But I've called this weak spots and intervention points in the Australian aged care system. And so going from left to right, there are inputs and staffing levels and mix has been inadequate in aged care, process measures, no training and infection control, no standards and no PPE systematically available to people. Outputs have been around a perverse funding model with inadequate funding, and on the outcome side, inadequate measures and a lack of focus on actually what really matters. And underneath this, I've sort of put that it's underpinned by a legislative and economic context. And the thing I would say about that is that the context itself has also created some of the perverse incentives in the system, and in particular, that aged care is structured to be separate from and unrelated to the health system, which is a perfect storm combination. But I guess I'd say more generally for an ECR watching this is that thinking about systems in this way across inputs, processes, outputs and outcomes is a really helpful way to structure research and structure research questions as well. This is what the current service mix looks like the Commonwealth spends about $20 billion. And if you think about Medicare, we all contribute to Medicare and pay for it out of our taxes. We're very proudly talking about Medicare as a public health system. Even though Medicare has a mix of providers, we have private, not-for-profit and for-profit, Medicare is still thought by us and regulated as though it's a public system, and culturally it is. The aged care system is 80% funded by government, and yet for some reason we define it as a private system based on the nature of the providers rather than a public system based on the nature of the funding source, 20% being consumer co-payments. The way that the system works essentially is you've got Commonwealth Home Support, which is the old HAC program, 850,000 people, low-level support, $2,800 a person. Home care packages ranging from 8,000 to 50,000, and then the lion's share of it being for about 240,000 people in residential care at $14 billion. Don't let anyone tell you that part of the problem in the residential aged care sector is that there's a whole lot of people there who could be cared for in the community if there was higher levels of care. That's not actually what the evidence says, but that's part of the mythology in arguing for more money for community. I'm not going to talk about community. I'm actually going to talk about residential. So what does the sector look like in terms of residential care? There's 180,000 beds. There's 240,000 people churning through those beds a year. So it's a 1 in 3 turnover, 60,000 deaths a year, and 60,000 people take their place. And that's a really important issue, is about the very frail nature. So less than 1% of Australians live in residential aged care, but 38% of all deaths in Australia are for people living in aged care. And one of the other groups I run here is the National Palliative Care Outcomes Collaboration. So we have 160,000 deaths, we had 167,000 deaths in Australia last year, and a bit over 60,000 of them are in residential care. In terms of COVID, we've had across the country about 28,000 cases, and we've had 908 deaths, the last being this week. Residential care has accounted for 7% of the cases, but 76% of the deaths, out of all proportion to the population in residential care, partly because the rate of infection has been very high and also because of the mortality rate. Our population mortality rate is a bit less than 0.9%, but in residential care, it's 1 in 3 people will die. So the context for residential care was a perfect storm. The Royal Commission had produced its interim report not long before, which they titled Neglect, and they describe a system that fails. It fails because it is unsafe and unkind. And they really described a system that had been left to its own devices for too long. And in part, that reflects the history of aged care, which was that it was all transferred to the Commonwealth, who conceptualised it as a social care system and not a healthcare system, which has provided the justification to dumb down the staffing and dumb down the funding. So essentially it's funded and regulated as a low care system, even though now all the people in residential aged care are very high care, because high care is not a lifestyle choice. Nobody is going to residential aged care by choice. They're going because they have no choice. So the structural weaknesses, I think, were very apparent before COVID came along. And in fact, this quote I've got here is from Peter Rosen QC in his opening address for the COVID investigation hearing they did, that the aged care system we have in 2020 is not a failing system. It is a system that's operating exactly as it was designed to operate. It was designed to fail. And so that's about a culture, a regulation, and a funding system that assumes that there's a trade-off between social care and healthcare. And you hear these adages all the time, oh, we can't have a clinical model. This is a person's home, as though you have to trade off social care or domestic style feel for competent healthcare, and the systems come down on the side of social care at the expense of health. I don't accept that trade-off, but very much that's how it's been seen. And I've been arguing very strongly in the sector that we need to start to really be recognising that residential aged care needs to be holistic and not just social. In a parallel universe to COVID, we were doing some residential care research commissioned by the Royal Commission, and I'm not going to go through that, but I will say something very clear about it. The evidence about residential care internationally is that quality and safety is driven by 4 generic factors: staff numbers, staff mix, so that's the skill mix you've got, staff continuity, and clinical governance. And in the case of COVID, there's also issues to do with physical design and PPE. On every one of these measures, the aged care system's failed. The government, when it took aged care back from the states and territories and brought it all together in the new Act, which was in 1997, deregulated the workforce. They stopped calling them nursing homes because you don't have to have a nurse on the premises. So there's inadequate staff numbers and inadequate mix. Casuals is a major issue in COVID internationally and is the single big, if I had to say what was the single biggest factor in Australia, it was casual staff. When we compared Australian staffing to the best available international evidence, which is the US, 58% of all Australian residents are in homes that would only get 1 or 2 stars in the American 5-star rating system, which was really quite shocking because most of us spend most of our lives feeling very proud about how much better our health system is to the American system. But the aged care system, ours, is actually worse. And only 15% of residents are in homes that would get 4 or 5 stars in America. We calculated for the Royal Commission and in fact for government as well, the cost of bringing the whole system up to 3 stars. And it's about a 37% increase in staffing in those homes that were inadequate staffing, representing about 20% increase in costs. So it's about doubling the budget across the country to bring everybody up to 5-star. The government's not going to do that. So they're the structural failings. Aged care was set up to structurally fail when COVID came along because it didn't have the right staff, it didn't have the right staff mix, and it didn't have the right culture. So what else went wrong on the day? Here's Victoria. There's 178 public homes. These are homes that get Commonwealth funding but substantially topped up by the Victorian government, which is also the case in a number of other states. They didn't have any COVID deaths. They had no major outbreaks. They had a few small outbreaks, but nothing major. Victoria had major outbreaks in 100 private homes, over 100. They had a mortality rate of 33%. And in most of the homes, the infection rate among the staff was around 50%. So in a home with 100 infected residents, they had at least 50 infected staff. The casual workforce was the single biggest factor. And in fact, the casual hotel security guard, the first one of the first ones infected in Victoria, lived with a casual aged care worker who promptly took COVID into the homes there and who then infected somebody else at work, and her partner worked in an abattoir, which is the other really high risk occupation. So it was a perfect storm. They had significant numbers of personal care workers, low-skilled, low-paid workers, paid casually, working in multiple facilities with little or no sick leave, and there were no provisions for pandemic leave. There was little or no training in infection control and in PPE. And in fact, I would have to say in the first major infection in New South Wales, which was at Newmarch, when the health staff finally got into Newmarch, they discovered that the staff there were wearing kitchen gloves because there were no clinical gloves in the whole facility. So that's a perfect storm. There were sort of 4, I'm going to talk about 4 Ps now. How do you do this better next time? The first lesson, I think, is that COVID entered homes via the staff. It didn't enter homes via the families. They locked the families out, which was never the problem. And in doing so, they substantially increased isolation, loneliness, mental health. There was inadequate infection control. The homes being private were considered by government to have to pay for their own PPE, and perversely, you only got access to the national stockpile after you had an outbreak, not to prevent you having one. And they did, as I said, have this very high rate of staff infected. And in fact, at a couple of homes, and I'm thinking particularly of something like St Basil's in Melbourne, which got a lot of publicity. At one point, they had no staff at all on the premises. Everybody else was either at home infected or at home in isolation. The second issue, my second P, is preparation. What really should have happened has been an on-site risk assessment of every single home to work out that they had the stockpile of PPE they needed and that they knew how to use it. And there was an agreed escalation plan on how to manage the first cases. And I have to say, I think the Commonwealth's response has been hopeless with aged care, because basically it said, look, we contracted out the care of old Australians to you private providers. It's up to you to manage this. Whereas they really fundamentally didn't have the skills. So what we really needed was some public health partnerships with homes at a regional level, facilitated by Commonwealth state agreements, which were not put in place until too late, that needed to include a plan. And Canada is the only country I know that's actually had a formal program called Families as Partners in Care. But also one of the biggest issues has been a number of of ambulatory dementia residents who physically are fine, they're completely asymptomatic, but have got COVID and have gone wandering. And that's been a major way that homes of COVID has spread within homes. The next issue comes really is really about the primary response, and fundamentally that's been about how do you manage the very first case. And what we know is that the only way that it worked is where cases were managed very fast and very assertively. And South Australia really did a fabulous job. They were the first state to decide to always move the first cases out, not to provide better care to those first cases, but to better prevent the spread of COVID in the people who were COVID negative. Other states, I think, were really far too slow to adopt a similar approach. In fact, New South Wales has been quite resistant. And the rhetoric has been, well, this is somebody's home, we have to keep them there. Every single state had enough hospital beds to manage the initial outbreak, but no state has actually had enough beds in the event of major outbreaks at homes. And I think most of the states and territories have had inadequate primary response plans because it's all been about containing COVID within the homes. My last P in my 4 Ps is about the pandemic response itself. And that's, what do you do when a full outbreak occurs? There were literally homes in Victoria who went from 2 cases to over 100 cases in just a few days, with 100% of staff in isolation. The lesson, I think, is that any major congregate living outbreak requires the complete separation of positive and negative cases, and that has been the problem on cruise ships. It's been the problem in aged care homes. We should have treated aged care homes like boarding schools. There's no way we would have kept everybody kid in the boarding school, even though they're a low risk group, and said, well, that's their home for this term, we're not going to move them out. What we had in aged care is 3 really big problems: shared bedrooms and bathrooms, open plan homes, and people wandering with dementia. The Victorians ended up opening 2 hospital wards for asymptomatic dementia residents who were wandering, in order to move them out of homes and try and control it in the rest of the homes, which actually worked, but were really high risk environments for the staff working in them, because the whole wards were people with dementia who were wandering and who had COVID. And I think the balance is about recognising that COVID is about meeting the clinical needs of individuals, whilst at the same time protecting everybody else. And that balance of meeting individual need and meeting public health need, I think, is something we needed a lot more debate on than we've actually had. This is my second last slide. Will the Royal Commission help? Well, actually, I don't think it will. The Royal Commission is going to do the obvious things. It's going to recommend more funding, more staffing, more regulation. But I don't think it's going to address the underlying structural issues, which is, I think, aged care should sit along Medicare being conceptualised as a public social good and not as a private competitive market. We should be really conceptualising and designing aged care as a human right, I found it astounding that people who were in aged care homes by choice, that is, they were not involuntary patients, actually had their doors locked, and they were actually locked in as though they left their human rights and their state citizenship at the door as they walked in. And part of that was about it being a competitive market, but also that we didn't get that aged care healthcare interface right. I don't think the Royal Commission's going to get it right. And therefore, I see us as at significant risk of another COVID outbreak, because I am not convinced that we've actually got the systems in place that we learn these lessons for the future. And this is my last slide, and I really want to make this point that epidemics are not random events, and they do shine a perfect mirror onto a society, and they find all the weak points. And in Australia, aged care was our weak point. We have, by any international comparison, done brilliantly well, except in aged care. And the fact that 76% of our deaths in the country are in aged care are absolute evidence that we did something seriously wrong. And I don't believe that we've done enough to prevent it happening again. Thank you very much.
Excellent. Thank you very much, Kathy. That was extremely enlightening, but also a real wake-up call. Now's the time for people to ask questions. If you could post your questions in the Q&A, please, at the bottom of your screen. Kathy, we have about 5 minutes for questions, so I'll start with the first couple. It sounds like a real pivot point, a turning point, was that deregulation in 1997. Do you think that substantial changes to the Aged Care Act might be possible now in the wake of this global pandemic, particularly given the disproportionate mortality that has occurred as a result, and as you've very clearly pointed out, systemic failure?
Yeah. If I go back to the Aged Care Act, up until that point, low care was regulated by the Commonwealth and high care was regulated by states and territories. And it is fair to say that nursing homes were too clinical. People, the nurses wore uniforms and it had a hospital feel. And so it was a genuine problem they were trying to solve. It actually just that the pendulum has now swung too far. And so at the time as well, there were lots of people in aged care who were there as a lifestyle choice. Some people still own their own cars and they retire, sell the family home and move into aged care. In the 20 years since, the retirement living industry, independent, seniors accommodation, all that stuff's opened up. So the people now going into aged care are all high care. I think the Royal Commission, I've done a lot of work. In fact, I've been working behind the scenes as a senior advisor on the Royal Commission. Lawyers, what I've learned is that lawyers are really good at identifying what the problems are and not very good at identifying what the system solutions are. They're going to go for the quick wins, the easy stuff, the more funding, more mandated staffing ratios, etc. I don't think they've at all grappled with this idea of integration between genuine integration on the ground. And in fact, I tried to get a national conversation going about splitting the aged care sector into two and transferring residential care back into health as the residential slow stream arm of the health system. And I couldn't even get a conversation about that. So no, I don't think the Commonwealth is open to the idea of better integration. The Commonwealth does not have expertise in managing service delivery. What the Commonwealth has expertise in managing is Commonwealth funding programs. And it manages aged care in exactly the same way as it manages Centrelink or something else. National queue, come and get on the national queue and apply.
Yes, yeah. Okay, thank you for that. The next question I have from Amal Trivedi is, why were there no COVID deaths in the 178 public facilities? Sorry, the screen's just moving. What strategies did they implement? Yeah,
the single biggest difference is that the Victorian public homes have mandated staff ratios. That is, you have to have a registered nurse on duty and you have to have a minimum amount of time. And our work that we did for the Royal Commission, and which Senior Council has included as recommendations in their final submissions, is mandated staffing ratios, including RNs and allied health. So the single biggest issue was having an RN on the premises who took control who took responsibility for infection control.
And so what are those ratios? Are they, you know, sort of publicly known? Is it a 1 to 6 or a 1 to 8 or a 1 to 4?
The Victorian ratios are a little bit different to what we recommended, but what we recommended across the country is that the bare minimum standard be 215 minutes, so 3.5 hours, with plus allied health of 22 minutes on average, case mix adjusted. I can provide people, if you're interested, with both. I was the expert witness to the Royal Commission on staffing on that issue, and we also did a very detailed research report, and we've also published a paper about it in the MJA. So it's very publicly available. Okay. That doesn't mean, of course, that government will adopt our recommendations, but there is very clear evidence about what the minimum staffing should be. So if I contrast that, our evidence showed that the average was less than 3 hours of care in Australia, and the minimum standard for subacute care in a subacute hospital, a slow stream rehab unit or whatever, is 6 hours of RN time.
Okay, yeah, quite a difference.
And the average in aged care is 30 minutes a day of registered nursing compared to 6 hours in a subacute facility.
Worlds apart. Okay, thank you, Kathy. The next question from Catherine Harding, again about Victoria. Compared to the other states, to what extent was Victoria's experience a poorer system to begin with versus bad luck? So in other words, would other states have been equally susceptible if they'd had experienced similar index events?
Other states would have been exactly the same situation in terms of their aged care facilities. The services are regulated by the Commonwealth, not by the states and territories. They're all staffed using a national formula, etc., etc. The difference in Victoria, as I think we've all understood, is that it had high population density in a city, which is Melbourne. So Melbourne and Sydney are the two high density cities. Density is one of the best predictors. New South Wales set up its regional public health units back in the 80s and major investment in the 90s and has maintained them ever since, whereas Victoria had a complete demolition of public health back in the Kennedy era. And to be fair to both sides of government, neither side, they both failed, neither of them rebuilt that contact tracing and public health infrastructure at a regional level. Mm-hmm. And I think it's the being able to actually understand your regions is where contact tracing's worked well.
Yes, terrific. And a final question. You talked a little bit about isolation and loneliness and the impact of shutting relatives out. Yep. Have there been any technological innovations or anything as a result of COVID that might help minimise future isolation and loneliness if another pandemic takes hold?
Yeah, lots of homes actually invested in iPads and Zoom meetings and all those sort of things. And for the non-dementia people, that worked pretty well. But for someone who's already quite confused or extremely frail, that actually in some cases added to the confusion. If I just talk about what the Canadians did very briefly, the Canadians had a program called Partners in Care where they said to families, come and be a partner during COVID. You actually have to get trained in PPE. You have to commit to come in for half a day at a time. It's not just casual drop-in. You need to join us as a partner in the care of your mum or your dad or your auntie or whatever. And a lot of families did that. The other thing that happened in Australia was a lot of families got really, really nervous and they actually came and took their loved one home. The providers I'm talking to are all saying every one of those people has been brought back because the families have actually realised they were really very high need.
Yeah.
But the other observation I would make is that national occupancy of resi care has fallen by about 2% in the last year for the first time ever since the Act was introduced in 1997. So there's a slight more increase in hesitation although people were already really hesitant to go into care. It's not a choice that anybody wants.
Yes, yeah, understand. Kathy, we're going to have to leave the questions there,
Thank
but
you.
we could talk on this topic for a very long time. There's a lot to cover. Thank you so much for being our invited speaker for the end of year event, and we'll be looking forward to hearing more of the outcomes of your work. Thank you. All right.